blood. Usually blood is, even you can do buccal smear. For example, take the water and give it to me, I have the cell. But usually blood is the better one. Doing karyotype of the blood is much easier than, for example, from the bone. So we usually check the band and kind of remembrance is very important. Your habit is very important. Are you stressful? Are you happy? That would be a very important issue to say the number easily. And the important issue is this one. Usually we have a standard karyotyping. In that one, usually 400 band for chromosomes would be checked. More than 550 and 850, it would be high resolution karyotyping. A standard karyotyping, high resolution karyotyping. That's different from each other. A standard karyotyping, it would be stopped in metaphase by colchicine. High resolution would be pro-metaphase chromosome. Here we have the chance to check for 550 to 850 band. By the best eyes, by the best microscope, doing very well checking of the test, usually we can find up to 2 to 3 million base pair deletion duplication. Less than 2 to 3, karyotyping is not good enough. So the important limitation of karyotyping is the resolution. Resolution means the megapixel of your mobile phone. Somebody says, my mobile camera has got 10 megapixel, others said 2 megapixel. Both of them can do picturing, but the resolution is very important. Up to 2 to 3 million base pair can be found out by high resolution, 10 million base pair by standard karyotyping. If something happened in less than 1 million base pair, we should go for RACGH or CGH or FISH or some other techniques. I will show you the picture, don't worry. So that one shows the mosaicism. It doesn't say about the number, but if its karyotype would be 46XX dash 45X means some of the cells are terminal, others are fine. P and Q, short arm, long arm. T means translocation, plus 13 means extra chromosome 13. Del means deletion. INV means inversion. So these are some of the numbers you can see and nomenclature of the chromosomes. Sometimes we say -5, or sometimes we say del 5. And for example, this one is P15. If another baby would be del 5, but P14, which one is better prognosis, which one is poor prognosis instead of 1.5 and 1.4? 1.5 would be severe because big number of deletion is there. 1.4 would be less. 1.3 would be less. So when it is deeper, it will be much more complication. In the next session, we talk about Robertsonian translocation. Remember, we have 5 chromosomes, 13, 14, 15, 21, and 22. They are acrocentric, which means there is no PR. But somehow there is PR, but very a small one, and it is a sticky end. So they can be sit together, 13 and 14, 15 and 21, 21 and 22. I will show you the picture. So that's the numerical problem, structural, we talk about this. Okay, very important issue. If a lady, for example, in the age of 20, has got a Down syndrome patient, all the family are fine. Somebody says, oh, because you had a Down syndrome patient, forget about pregnancy. This is not a good, this is not right. This is not an issue. Only 1% would be added to this lady because of the previous pregnancy to have another baby with this one. So we asked them, don't worry, everything will be fine. Please go for another baby as earlier. For example, in this 20, at the age of 45, you wanted to have it, so you have at risk of the age of 150 because you are 45, plus 1% because the previous baby. Do you hear what I'm telling you? Then we have a lady, for example, in 22, she has a Down syndrome patient. Shall I forget to have a baby? Shall I go for tubal vacation? The answer is no. Even I am a mosaic Robertsonian translocation carrier. We don't say no, don't worry, don't go for another baby. We ask them, you are Robertsonian translocation, you should do directly amniocentesis. Forget about screening. Okay, somebody come again with previous baby of the history of Down syndrome. We add 1% to the number we had for the age. 1% extra because of the previous one. So nobody can say because of that history you should forget to have another baby. That's a big problem we have. 1% more as the regular carrier of translocation should be referred to the genetic clinic at risk. At the risk of child with serious malformation may be hard. So because of the Robertsonian translocation, they go directly as the same as of the lady with the age of 35 and more. So the resolution is very important. Usual karyotyping 10 million base pair. High resolution karyotyping 2 to 3 or 3 to 5. Usually some people 3 to 5, some people 2 to 3, doesn't matter. Otherwise you should go for fish. Fluorescent in situ hybridization. In that one, the resolution would be even to the size of 10 to 30 kb. We have a specific probe on that part of the chromosome to see, is it 2 copy? For this green is 2, but this red is only 1. This means this red is deleted in that patient. So the deletion is 10 kb, 30 kb, 50 kb, less than standard karyotyping. We will go for fluorescent in situ hybridization. Also, we have the technique for array to check for this one. So we finished the first session. I forget to tell you, please read Emery's Element of Medical Genetic, chapter 3 and 18. These 2 chapters are on the cytogenetic study, and both of them are very important for you to read. That's the first session. We will go for the second session. Since now we are in structural, then we go for sex chromosomal abnormality. Okay, that's X chromosome, that's Y chromosome. It is very interesting from each other. We talk about this one. First I say about the structural abnormality, then we go for the sex chromosome abnormality. As I said, usually go for blood, but we can go for buccal smear, we can go for sperm, we can go for urine or defecation others. We usually need the cell with nucleus. We add phytohemogglutinin to have much more division. 3 days at 37 degrees, incubator CO2. Then we add colchicine. Anybody know colchicine as a kind of drug? When we use colchicine? Some of you should know colchicine. Can you see this colchicine? Usually we use it for goat, نقرس باللغة العربية. Goat. G-O-U-T. The people who eat too much meat, for example, the king, queen, they have much more meat. They have uric acid. Too much uric acid results in goat, necklace. Have you heard necklace? Yes. That's the necklace. These colchicine are used for the treatment of acute necklace or acute goat, plus usually used for the cancer therapy. In the cancer, as a kind of adjuvant chemotherapy, we use colchicine. Here we add colchicine to the cell to stop them on the metaphase. So this drug, the colchicine, sorry, this drug, not this drug. The colchicine here can be used to stop the cell with too much division. Because the cancer cell has a lot of division, we wanted to stop it. Same as this cell division. We stop them all in the metaphase. So you can remember this drug colchicine. Then we fix the cell by the hypotonic saline. Then we take a smear and we see it on the microscope. Under the microscope, this is very noisy, but based on the number, based on the centromere, based on the size, based on the band, we can say this is chromosome 1, this is chromosome 2. They are healthy, they are fine, they are not fine. Let's go try to find out what's going on. So, this is the three kind of chromosome we have. The majority of them are metacentric. Some of them are sub-metacentric. But here, important issue is acrocentric. Chromosome 13, 14, 15, 21, and 22 are acrocentric. Previously, we thought there is no PR. Then we realized, no, there is PR there, but it is sticky and very small. This means can stick together in trisomy 13, 14, 51, 21, and 22. That's named as, in the structural chromosomal abnormality, the number is fine. The structure is the problem. The number is fine. The people who are carrier of this kind of translocation are at risk to have a baby with the problem. Usually this carrier, they are fine, the phenotype is fine, but somehow they have borderline mental retardation. Somehow they are on the very easy job. For example, they are cleaner, they are guard. I don't want to talk about these people as bad people, they are fine, they are very needed. But somehow you can say, somehow there is something wrong, but the hand is fine, food is fine, heart is fine. But the important issue, they say, we had several pregnancy loss, we have several abortions. My mother had it, I have it. This means something wrong. This is a carrier of translocation happening again in the health of the baby. The problem is the baby. So remember that deletion, duplication, inversion can happen. Here the number is fine, but each chromosome has got this kind of problem. Balanced translocation carrier, the father and the mother. Since all critical genes are present in double dose, this person usually has a normal phenotype. The problem is when they form the gamete, the sperm or ovum, and the risk is happening again. So they are Robertsonian translocation, and the risk is high for the other baby. For this kind of couples, we don't go for a screening, we go directly to amniocentesis. Okay, usually structural chromosomal abnormality is cryptic, is not clear. So we should check very clearly to understand there is something wrong on the chromosome because the size is small. Usually this happens in the subtelomeric region. Usually we need some specific probe, for example, doing FISH to understand there is something wrong. Otherwise, chromosomally, it seems to be normal. So we say microscopic deletion, less than 2 to 3 million base pair. Usually we don't find them easily by karyotyping. For example, I say, if you think the baby is unhealthy and the karyotype is normal, don't say my diagnosis is wrong. Maybe the resolution is the problem. It's not easy to define by a standard karyotyping. So usually this microdeletion syndrome, micro means smaller than can be seen by the microscope. Usually happen in a specific chromosome, chromosome 1, 7, 8, 11, 15, 15, 16, 17, 22. It means some specific chromosomes are prone or at risk to have this kind of problem. It's not happening in other, for example, chromosome 2, 3, 4, this seems to be fine. Some of the disorder named as a kind of a specific part. Some of them are named by the person who described for the first time. Some of them is abbreviation. VAGR is abbreviation on some chromosomal abnormality. How this happened, we don't know why. Usually this happened because they have the same sequence and they are at risk to result in deletion or duplication. The chance would be haploinsufficiency. We are diploid, we are sufficient, we are fine. But here they are haploid and it is insufficient, it's not enough, result in the problem. It can happen in terminal part of the chromosome or interstitial part of the chromosome. Based on the number of chromosomes, based on the number of genes and also the function of the gene, patient would be very severe, some patient would be a little bit better. How we find it out? If it's more than 2-3 million base pair, we will find it by the karyotyping. Less than that, we should go for FISH, PCR, sudden blood, RACGH, CGH. These are other techniques we named as molecular cytogenetics. These are molecular cytogenetics. Usual cytogenetic techniques are not helpful. Let's go for some samples. 4P deletion, named as Wolff-Hirschhorn syndrome. Two people, Wolff-Hirschhorn, two people who described for the first time this disorder. Here again, you can see 46XX del for 5 or maybe minus for P. It happened in 150,000, much less than the Down syndrome or trisomy 13 and 18. They describe the disorder distinctive Greek helmet facies. The face is as a kind of Greek helmet. They have 50% risk of cardiac defect. It was 40% for Down syndrome. Mental deficiency, very severe, IQ less than 20. Same as trisomy 13 and 18 here. The IQ is less than 20, very severe. Again, if you definitely can say this baby on that mother has got 4P deletion, you can go for therapeutic abortion. 1/3 of them will die in the first year. Frequent seizure. Again, I'm telling you, seizure is quite common. Seizure can happen due to fever. Seizure is not a big issue. But if as a baby has got seizure without answering to usual drug and they have some anomaly, or maybe the baby weight was very less, or there was microcephaly, or there is some deformed ear, please go for karyotyping to be sure. Cytogenetic is fine. And it is interesting, in 4P, 85 to 90% they are de novo deletion. De novo means father is fine, mother is fine, the baby has it for the first time. De novo, it means the sperm and ovum is fine, but maybe something wrong result in the 4P of the baby. So it is de novo mutation. De novo means for the first time. To find it out, sometimes by karyotype, when the size is big, you will find it by karyotype. Otherwise, you go for FISH. Again, you see the control is there. We usually one color for control, one color for the specific form. Here, this chromosome is fine because we have this, but here there is a deletion. We don't see it here. And in the 4P, the size is usually 165 kb. 9 potative gene is in the 4P. And when this part is deleted, means 9 gene is vanished. There is haploinsufficiency, result in the big number of sign and symptom in the baby. Again, 5P, clear to chat. Incidence is the same. Here the problem is 1% of baby who are institutionalized because they are very problem for the family. Family says, oh, we can take care of this baby. Let's go give it to the institute to take care of the baby because they are very problematic because of retardation. Usually they have a cat-like cry in the first year of the age of the baby, growth and developmental deficiency, microcephaly, third of them has got heart defect. In Down syndrome it was only 40%. Round moon-like face, IQ less than 20. Many survive into adulthood, compared with 4P, which many of them die in the first year. Here, many of them go for adulthood. Even you can see hypotonia. Even she can't take care of the hand and needs another hand to take care of this one. As you can see, the majority of the example I'm telling you is XX, but I told you, male and female on the chromosomal abnormality, the same frequency. These are not a bias. Here you can see 46XY, del5, P14. I told you if it's P13, less affected. P16, more affected because the bigger size of the chromosome are deleted. Here you can see some of the phenotype of the baby. I'm not going to go into all of them, but you see hypotonia is there, low set ear is there. I told you, please take care of all organ. Take care of whole baby. If a mother comes and says, this is my daughter, she has short stature, don't say, okay, short stature, let's go for growth hormone, let's go for zinc, let's give up a lot of acid for you. No, take care of amenorrhea, take care of hand, take care of feet, take care of the external genitalia. Baby, there is a problem on the baby, please write it down. Usually, we check the whole baby, not only hand, not only kidney, not only eye. Whole baby, and also check whole the family. Is it a problem whole family or is it a problem on that specific baby? 4P, 5P are structural abnormality. Chitotype 46. The number is fine, but some part of the chromosome is a problem. Here another one, microdeletion Williams syndrome, 7q11. Usually because the size is small, by fish can be diagnosed. They named as Williams Burion as well, two names. We have hypocalcemia, which can result in the seizure. We have supravalvular aortic stenosis. When you have the baby, you will hear the heart sound. It seems there is something wrong on the heart sound. What is the first exam you will ask? If there is something wrong on the structure of heart, when you hear by hearing of the heart? ECG. Sorry? ECG. No, ECG is for the example for myocardial infarction. ECG is needed if there is tachycardia or maybe bradycardia. We go for echocardiography. Echocardiography means sonography of heart. Echocardiography. For any structural heart problem, we go for echocardiography. You check it, it says, unfortunately, ASD, means atrial septal defect, VSD, ventricular septal defect, tetralogy Fallot, PEA. Or we say here, supravalvular aortic stenosis. Supravalvular aortic stenosis. Why this happened? There is some stenosis in the aortic valve. It is supra. Because when we have deletion of 7q11, there is a gene named as elastin. This gene is vanished on that specific baby, result in the supravalvular aortic stenosis. They have mild short stature, a full lower lip. Their lower lip are not with gel. They are having a problem of the genetic problem. Full lower lip, a sloping shoulder. The shoulder are sloping. Also, they have cocktail party manner. Without drinking alcohol, they are laughing too much. when you see somebody laughing too much, you say, okay, maybe you are in the party, don't go, it is haram, let's go for shallow, something like this. No. Here, they are laughing too much. Cocktail party manner. This is the first example of a behavioral genetic problem. Behavioral genetic problem. Because of the retardation, they have it result of laughing too much. Here is a picture of one patient in different age. Of course, he is not laughing, unfortunately, but you can see lower lip are full, and you can see a sloping shoulder. A sloping shoulder, full lower lip. Of course, shorter saturation cannot be seen. Why this happened? The frequency is 1 in 7,500. There is a contiguous gene syndrome. Several genes tail to head of each other are deleted. 1,400 kb is deleted. One of the important genes is elastin, papillary insufficiency, resulting supravalvular aortic stenosis. LIMK1, CYLN2 result in metaretardation. They have distinctive facial feature. Only you can see the face is not normal. The ear are low. Maybe there is something long on the ear. Hand is much more finger. Club foot is there. Hypotonia is there. 3 organ involvement. Let's go for karyotyping. Again, and that's the kind of cocktail party manner. They are laughing without any reason. By the fish, you can see the contour green is 2, but the red one is only 1. Here we don't see that one. It means 7q11 is deleted. Robertsonian translocation and also reciprocal translocation. In Robertsonian, chromosome acrocentric 13, 14, 15, 21, 22, they are sticky and they can sit together. We have 14 and 21. A sticky end result in the derivative 14 and 21. This patient will be Down syndrome patient because of 2 chromosome 21 more than normal. Here you can see. This woman, this woman is normal, phenotypically normal, but the baby would be abnormal because 2 chromosome 21 can be in the ovum. A structural chromosomal abnormality would be 1 per 375. It can be balanced, reciprocal, or Robertsonian. Robertsonian for chromosome acrocentric, reciprocal for other chromosome. It would be unbalanced resulting deletion, duplication, isochromosome, ring chromosome. I will not go through them because it's too much and very hard to understand. Reciprocal would be interstitial chromosomal abnormality, not terminal, same as Robertsonian. Again, here you can see part of chromosome in the interstitial part from chromosome 3 went to chromosome 21, and we have extra chromosome 21 out of it. Again, same as Robertsonian, carrier of this kind of translocation, they are fine, but the problem would be on the sperm or ovum. So this is very important. Another molecular cytogenetic study would be CGH, comparative genomic hybridization, conventional or array. When the color would be yellow, it means everything is fine. It would be green, it would be deleted. If it would be red, it would be duplicated. Part of the chromosome can be deleted or duplicated. These are the techniques we use for molecular cytogenetics. Usually, we have the chromosome of the control, we have the chromosome of the patient, and we check with the array of the normal people to be checked, is it deletion or duplication, or they are fine.
What is the difference between Robertsonian translocation and reciprocal translocation?
I said Robertsonian would be for the autocentric chromosome 13, 14, 15, 21, and 22. Reciprocal would be for the others, but the others is the same. Only the name would be changed. The other issue is the same for the reciprocal and Robertsonian. Okay, now we stop this part. We will go for the sex chromosomal abnormality. If you want for a break, you can go for a break. After 5 minutes, I will start. We talk about X and Y chromosome. It is very interesting. Nowadays, they say the Y chromosome of the mouse is vanishing. So some people say, is it possible for the human being to be happen? So somehow ladies are looking for vanishing of the Y chromosome of the male, same as the mouse. Usually we have these numbers: sex chromosome aneuploidy, extra X for the male would be Klinefelter. The frequency would be 1 in 1,000. Extra Y, again 1 in 1,000. Other X and Y aneuploidy for male would be 1 in 1,350. Total 1 in 360. So means if you help to have delivery of 360 boys, one of them has got the problem of the sex chromosome abnormality. For female, Turner syndrome 1 in 4,000, triple X 1 in 900, other 1 in 2,700, total 1 in 580, which means sex chromosomal abnormality is much less in the ladies than in male, nearly two times. The remembering data is, instead of autosomal chromosomal abnormality, in sex chromosomal abnormality, the problem is not too much. So you see in autosomal chromosomal abnormality, you see hand, heart, IQ, everything was problematic. In the sex chromosomal abnormality, usually they are normal. Forget about Turner syndrome. Turner syndrome, there are some issues, you can find it out in the baby. Otherwise, in the puberty, on not having baby, on delivery, on infertility, on spontaneous abortion, you can say, okay, the mother or father is not fine. So prognosis is much better for sex chromosomal abnormality compared with the autosomal chromosomal abnormality. So by the delayed puberty, you can say, okay, maybe this lady has something wrong, or male has got something wrong. Forget about Turner syndrome. Turner syndrome is an exception. Let's go to see what exception is there. Okay, about 50 years ago, we realized Y chromosome is crucial for male development. It's Y chromosome is there, it's male. Y chromosome is not there, it would be female. The Y chromosome has got very specific gene, same as a specific region Y chromosome. Maybe the Y chromosome is there, but this part is deleted. Only this part is deleted. It would be a lady. Y chromosome is there, but a specific region in Y chromosome is deleted. The product would be a lady. DAS gene, deleted in azoospermia. This part is deleted. It's male. Y chromosome is there, but the sperm would be 0. Then you check for semen. You do check of semen, it's normal, everything is fine. You do checking of sperm, it says oligospermia, the number is less. Azoospermia means 0. There is no sperm. Why this happened? Because of deletion in the DAS gene, deleted in azoospermia. And it is interesting, you know, autosomal chromosomal region are divided to each other. We are recombinant. It is very interesting. Same father and mother, we have recombination. So one of the brother is same as mother or same as the uncle, other one is same as the father, same as the paternal uncle. Recombination is physiologic. We have the recombination. Why we have recombination? Because of the autosomal region exchange. For example, we say half of mine is from father, half of mine from the father or mother. This is not true. Maybe all my chromosome 1 is from me, from mother, my brother is from the father. This is happening. That's in the autosomal chromosomal region. Exactly the same in the Y and X chromosome, we have so the autosomal region. The place change can be happen. So maybe you can say, okay, this boy is tall because the maternal uncle is tall. This boy is bald because of the paternal uncle is bald. This has happened. Okay, Y and X chromosome are structurally distinct from each other. Maybe they have common progenitor. Y chromosome lost many of the genes, remain only 50. It is interesting. The X chromosome has got 1,600 genes. Y chromosome has got only 50 genes. So, because one of the X of the lady are inactive, and because the Y chromosome has got only 50 genes, men and women are not different from each other too much. Only on external genitalia. Male has got prostate and testes, lady has got ovary and uterine. That's the difference on the male and female. They have some different on the hormones, others is the same. Because one of the X of the lady is inactive, because of the Y, the chromosome has got very few genes. And that's the part very important. So the autosomal region in two parts of X and Y, they are pairing, and meiotic recombination occur in that location. Maybe a mother and father has got 6 girls, and the girls are different from each other. Why? Because of the pseudoautosomal region of the chromosome X is different from each other, they are recombinate. And you know, there is a tanavur, there is a kind of variation, and it is very beautiful. And it is physiologic. Recombination is physiologic. From the first time when a sperm and ovum get together, the sex selection would be there. But up to the age of 6 weeks, both gonads are come down. From the age of 6 weeks, after that, there is differentiation to be a male or female. Anything as a kind of mutation happen can result in the difference between male and female. You see, up to the age of 6 weeks, they are bipotential gonad. If the Y chromosome is there, it will go to testis. If the specific region for Y chromosome or testis determining factor is there, it will go to be male. If Y chromosome is absent, it will go to be female. Androgen is there, male external genitalia. Estrogen, progesterone, female external genitalia. These are other important issues in this regard. Forget about this one. Okay, this one is very important. Maybe the question comes from this slide. SRY region absent, it will be female. Present, male. Hormones, androgen, progesterone is there, female. Androgen, male. Anti-Mullerian hormone is too much, it would be male. Some of the infertility is because of the AMH. We check the AMH and we say, okay, it's too much, so because of that, there is infertility. Testosterone, check. Estrogen, progesterone normal, it would be female. Androgen receptor, estrogen, progesterone receptor are normal, it would be female. Abnormal, it would be male. Androgen receptor normal, it would be male.
Male.
Androgen receptor mutated, it would be female. And 2X chromosome, it would be female. 1X, 1Y would be male. DAS gene for deleted azoospermia. We have another copy, azoospermia factor 3, A, B, C. Any of them is deleted, result in the azoospermia. Let's go for some clinic. The Turner syndrome happening 1 in 4,000. Survive to term is rare. 99% of Turner syndrome baby would be aborted. Only 1% of them come to the live birth. 50% of them are full monosomy 45X. 25% would be mosaic. Usually caused by paternal error meiosis. The father doesn't give the copy to the baby, it would be Turner syndrome. Weblek, they have Weblek. This is exactly the picture of the patient was described by Turner as a kind of Turner syndrome patient. Also, they have lymphedema on the fingers and on the hand and toe. Weblek, lymphedema are the symptom of the Turner syndrome patient. They have short stature. They have gonadal dysgenesis, sterilic gonad, Weblek, broad chest, elevated frequency of renal and cardiovascular anomaly. And it is interesting, this X comes from father would be different if the X comes from the mother. The lady are normal, one X would be inactive, but very different from the Turner syndrome. Why? Because we don't know why this happened. The patient X derived from the mother, which means paternal is lost. This patient tend to have significantly worse social cognition skills. Short stature is there, but the X is from the father and the mother, they are different from each other. But the IQ is normal, even high. Turner syndrome patient, they have normal IQ, so nobody can go for therapeutic abortion if the baby is Turner syndrome. So please write it down. Screening for sex chromosomal abnormality is forbidden. You can't say, okay, this is Klinefelter, let's go for abortion. This is Turner syndrome, let's go for abortion. Because the IQ is normal. The IQ is normal, we will not go for therapeutic abortion. Lymphedema after some age would be vanished. It's not there. For the first years, it would be there. But you know, Weblek is there. You see, Weblek is there even in the old age. In the Turner syndrome, we have short stature. It is Klinefelter, it will be tall stature. The Klinefelter will be XXY. They are 47. They are kind of aneuploidy, but in the sex chromosomes. They are tall, they are thin. Thin means they are not obese. They are not various. Long leg, long hand. Hypogonadism. In the Turner syndrome, only by sonography you can say there is no ovary or they are very strict gonad. Exactly the same XXY. Here there is no testis or very, very small testis. Usually the question is, okay, I am Klinefelter, can I have a baby? We will do sonography, we will do sperm analysis. Also we take biopsy of the testis. Maybe from that one we can find one sperm, two sperm, and we can help for the fertility of the mother. They have some semen, but there is no sperm on it. They have the voice of the ladies. Also, they have gynecomastia. Gynecomastia means a kind of big breast for the male. In the obesity, you can see that. Nobody can say, okay, this baby has got gynecomastia, so he is Klinefelter. No. Obesity can result in the gynecomastia. Please check on that baby. The testis is fine or small. The penis is small or it is fine. The voice is much more ladies or male. Also, they don't have a kind of usually infertile. The Klinefelter. The frequency is 1 in 1,000. Is it only XXY? In some variant we have 2X2Y, 3X1Y. All of them named as Klinefelter. The name is not different. And it is interesting, all extra X chromosome would be inactive, same as the ladies who are inactive X chromosome. But you can result on the tall stature and there is no testis, something like that. Extra X, more abnormal phenotype. Even they are inactive, which means X inactive in the ladies are not full. Part of X chromosome can be same as the other inactive X chromosome. Another issue is extra Y, XYY. Somehow they say extra Y, they are antisocial. Then they realized they did a big mistake. They did checking of the people who are on the prison. And in that one, because of bad sampling, you can't say extra Y means you would be crying, you would be go to prison. No, because they did the example from the prison, that was the problem. But they are hyperactive. So if somebody say, okay, my boy has got a little bit a little bit metal retardation, they are hyperactive. Because of metal retardation, you can do karyotyping. Maybe that would be extra Y. They are not big issue on the metal retardation. They are tall, same as Klinefelter. They are fertile in versus with the Klinefelter. The Klinefelter is unfertile, but extra Y can be fertile. They have severe acne. So please don't say any boy in the street, if they are severe acne, say, okay, maybe it's extra Y, let's go for karyotyping. But these are some of the phenotypes you can see. IQ about 10 points below average, maybe 70, 60, something like that. But it's not the reason for abortion, for Klinefelter, for Turner, for extra Y, we don't go for therapeutic abortion. Hyperactivity, attention deficit, and impulsiveness. Some kind of waswas they have on that one, in this one, extra Y.
Sir, if all the X chromosome, extra X chromosome is inactive, then why there is
not all. More than one would be inactive. Same as the lady. A lady has got 2X. Extra than one would be inactive. So triple X, 2X would be inactive. 2X, 1X would be inactive. Without X inactivation, it would be gone, not alive. Turner syndrome has got 1X. If it's inactive, okay, nothing.
But in addition of Y, if there is 2Y, the 2Y is...
There is no inactivation for Y chromosome. Maybe you haven't been in the class. They said the mouse Y chromosome seems to be vanishing. Maybe in the future there is no male with Y chromosome. Because you see, there is not important genes there, only for fertility we need it. So the feminism are looking for vanishing Y chromosome. So triple X, again the same 1,000, 1 in 1,000, female nerve, somewhat tall. You see, seems the gene for having good height is on the X chromosome. A slightly smaller head, go through puberty without any problem, usually fertile. Same as extra Y, triple X is again fertile. 70% a little bit problem in the learning, delay in gross motor skill. Quadruple X, 48 XXX, more severe, much more X, much more severe problem. Of course, more than one would be inactive. Again, We have same problem for male and female. Again, the same feature. And this one, ambiguous genitalia. I told you in the first slide. Ambiguous genitalia is a emergency, neonatal emergency. Don't say he or she in Arabic. Don't say anta, ante, or what is that other one? He, huwa, hiya, not something like say this baby, this patient, because maybe they will go for having a certificate of birth and they go for name, but maybe this is not lady, this is male, and something like that. Usually we work on a teamwork, a gynecologist, a pediatrician, the mother and father, a psychologist, plus geneticist sit together to describe the patient. Okay, do we have ovary? Don't we have testes? Is it in the abdomen? Try to take it off or take it down. What you are looking for, we should do karyotyping. Also, there are the problem of hypertension in some of them. Some of them has got electrolyte problem. We should check for that. So a teamwork regarding ambiguous genitalia should sit together and find out what we shall do. Shall we go for any kind of surgery? Is it a male or is it female? Having two sex together is very, very rare. Hermaphrodism. Mild hypospadias. Instead of having the end of the urinary tract, is it up or is it down? It would be mild hypospadias. It's a kind of ambiguous genitalia, of course. Hermaphrodism, both ovary and testicular tissue is present, is very, very rare, but they should sit together with the mother and father to describe the situation, and let's go for having male or let's go for being female. They will decide. But all of them should do karyotyping.
Sir, in a female, if there is an extra X chromosome, is it super fertile? Because
No,
there is an
not
extra.
super. We don't have super fertility or not. If you are asking somebody, because we have time, I'm telling the answer. Somebody went to Canada to a kind of a fertility center, and they realized, oh, this boy is similar to my boy. They are very similar to each other. Then they confused why they are so similar to each other. Let's go to try. They called the police. Then they come. They realize the person who are working there give his sperm to all the ladies. They are super fertile. But this is not an issue. It's unethical. And we don't have super fertility. They are fertile, they are infertile. I don't know what's the meaning of super fertile. Do you mean about having twin or something like this?
No, if there is an extra X chromosome, so the fertility is more than normal.
You know the answer is wrong. Having, for example, somebody has got in this sperm has got 3 million, another one has got 1 billion. Is it super fertile? No. Thank you.